through it and just make sure that y'all have a real solid understanding of IV therapy. So before we get started, and again, I probably have said some of this to y'all in class, but I just want to point it out to you guys. Well, you can't see because my thing is blurred because my kids are home from school today. The Louisiana State Board of Nursing has its course objectives, and that's the stuff, all of the stuff that whenever you're finished with this course, you have to have a good understanding of. So I'm going to go back to that scope of practice a whole lot because the State Board of Nursing, they develop basically they determine what you can and cannot do. And at this point in your career as LPNs, they say the actual statement within your State Board of Nursing guidelines, which is what you go by for your Nurse Practice Act, is it says the scope of practice for LPNs in Louisiana does not require national certification. However, the LPN should have the knowledge, skill, and ability to perform the assigned IV therapy task. So what that says is that your nursing board is saying we are covering all of these things. And by covering all of these things, they are saying that you do have the knowledge, the skills, and the ability to perform the task if you pass this IV course. But that doesn't mean that you can always do it in the facility in which you work. So it's very, very important that you know what the policies are where you work. And we've kind of talked about that a little bit in class. The LPN has a little more leeway at post-acute medical at PAM than they do at North Oaks. And the LPN will have a little bit more of a, it truly just depends on where you work. If you decide to travel nurse and all that stuff, it will vary from state to state regarding the licensure. So pay attention to that as well, okay? So if someone says LPNs cannot hang blood, that's actually not true. If they say LPNs cannot give IV push medication, that is not true. And if they say that LPNs cannot touch PICCs, that is not true. However, it will vary facility to facility. I know I've said it multiple times, but I want to make sure that y'all have a good understanding so you don't mess yourself up, okay? So that being said, let's get started. Introduction to IV therapy. All right. So some of the stuff that we're going to learn, well, first of all, let me also tell you guys, this is one of the books. Let me unblur myself and my kids walk in the background just, well, I don't know how to do it now that I'm on here. Your DeWitt's Fundamentals book, it's green. Do y'all know the one I'm talking about? Looks like this. I don't know if you could see it. Y'all used it with Miss Lott in Foundations. Do y'all have that book still? Y'all rented it? Okay. If you rented it, let me know because I need to copy chapter 37 for you, or one of your friends does, because a lot of the information that I pull from chapter 37 of that book, if you have it in the e-form. And actually, excuse me, chapter 36. Chapter 36 of that book, which is administering intravenous solutions and medications. Also, that information can be found in the ATI modules that you're going to do, as well as your Roach's book, the last chapter in that Roach's book too, which is chapter 54. So all of those places I'm pulling stuff from. Okay, so some of the key terms that you guys need to be familiar with, and we will go into them, and if I don't go into depth with them, I want you to look them up and ensure that you know these names. Chemotherapeutic and chemotherapy. So we're gonna talk a little bit about that. Colloid solutions, crystalloid solutions, which y'all saw my little IV therapy board that I made. And that has examples of those solutions on there. Cytotoxic, homeostasis, IV therapy, maintenance therapy, osmolality, peripheral inserted central catheters, replacement therapy, restorative therapy. So This is a little link that has the solution overview of different types of solutions. I'm going to discuss that with you guys, but you can go back and watch that little video if you want to. So as far as IV therapy goes, blood transfusions first began in the 17th century. And then Sir William Henry discovered blood circulation in 1616. IV therapy was banned post experiments of injecting wine and opium into the bloodstream. So before we really got this figured out, there was a whole lot of stuff that was played around with, and like, oh, we can put this directly into the bloodstream. Let's see how this works. And even though that seems a little crazy, do we not do the same thing now with people who shoot up heroin? They're injecting opium into their bloodstream. So all of that stuff is unfortunately not too far removed. The 19th century is whenever we started seeing, like, yes, blood transfusions are a good thing, but if we're not doing them in such a way to control infection, then we're really not doing anything. Dextrose was first added to IV fluids in 1925. D5W and D5 normal saline were in the mid-1950s is when we started seeing that. And then in the 1960s is when we really started seeing medications given IV, and, really it being a part of people's care. So why do we start IV therapy? We've kind of talked about this as a class. It is not just because it's easier because your patient is non-compliant with their medications. It's not just because it's faster or because it's easier to manage. The overall goal is to restore normal fluid volume and electrolyte balance. So the goal of IV therapy is homeostasis. So if our patient is fluid deficient, then we want to give them the fluids that they need in order to regain that homeostasis. If we need to quickly administer medications, like in an emergency event, then we're going to use IV therapy. And then nutritional therapy. We're going to talk about PPN and we're going to talk about TPN, both of which are delivered, through intravenously. Excuse me. If our patients can't take PO meds, and they must have them, we can give them IV. Patients who need meds that can cause detrimental effects if given any other way. So some medications can only be given IV. So of course we would give those medications IV. If our patients are unconscious, if they have dysphagia, or if they're vomiting and they can't keep medications down, those are all reasons that we might expect for IV therapy to be used. If our patient is immediately out of surgery and we are giving meds IV for that patient, at what point would we say, like, I guess I'm trying to think how I want to ask y'all. Okay, at what point do we say, okay, let's switch this patient to PO medications if they're right out of surgery? So why were we using them initially out of surgery? What was our reason that we were giving them? Y'all gotta talk to me a little bit.
Maybe for pain.
Okay, so they were in pain. So we needed it to work quickly. Mm-hmm. What is another reason that we were given these medications right out of surgery?
Infection control?
Not really. Based on the list that's in front of y'all.
Because they're unconscious.
Yeah. So they're not fully awake, alert, oriented, and we need it to work fast. Okay, so as they wake up, as they go from the recovery room into their room to stay the night, we want to keep in mind that we don't want these patients to stay on this IV therapy medication forever because it's really no longer indicated. Once their pain is well controlled and they are awake and alert, then IV therapy, given meds intravenously, is not the preferred route, right? Because they can't go home like that. So we always want to plan, I'm sure Ms. Lott had taught you guys this in foundations as well. we always want to plan with discharge in mind. Like discharge planning begins upon admission, because if we don't, then our patients are there for an unnecessary length of time. And IV therapy is something to keep in mind when we're doing that. IV therapy is a great thing, but we shouldn't just use it because that's how we did it when they first came out of surgery. We want to ensure that we're using it appropriately and when indicated. Okay, so 3 different types of therapy. We have maintenance therapy, replacement therapy, and restorative therapy. Those are your 3 main types. So maintenance therapy provides the nutrients to meet daily requirements of water, electrolytes, and nutrition. It's used for patients who can't take or have limited PO intake, and it's most frequently seen in inpatient and home healthcare settings. Replacement therapy, the patient is fluid deficient for 48 or more hours. A patient who has nausea, vomiting, diarrhea, starvation, or hemorrhage. This replacement therapy is going to be given more rapidly usually. It's more, they have lost something and we are giving it back. So in regards to homeostasis, right? So let's go back for a second just so y'all can have a good understanding and you can apply it. So maintenance therapy just keeps them maintained, right? It's just giving them the amount that they need to remain in homeostasis. Replacement therapy, they have lost something, so we have to give them and bring them back to that homeostasis. So sometimes it's given rapidly. Sometimes it's given, it depends on what they've lost. So if they've hemorrhaged, what are we giving them? Come on, guys. If our patient hemorrhaged, what are we giving them in their IV? I didn't hear you.
I was about to say replacement therapy, but
we are, but what specifically?
So if they hemorrhage, you're going to give them blood, right?
Yes. So if they hemorrhage, we're giving them blood. If they are in starvation mode and they're completely depleted and they cannot take no intake whatsoever by mouth, what are we giving these patients?
Food, not food, like.
So essentially yes, TPN or PPN, which is that total parenteral nutrition. And then, so their kidney function must be assessed prior to the fluids being instituted. So we have to make sure that if we're giving them large amounts of fluid or it's not always a large amount, but it's usually given over a more quickly time period than maintenance therapy. So we have to make sure that their kidney function is up to par. Otherwise, what are we doing to these patients, y'all? If we're just loading them up with fluid and their kidneys are shot, what are we doing?
Fluid overload.
Yep, we're sending them straight into fluid overload. Are we helping them in any way? Nope, we're giving them a whole lot more problems. And then, so if our patient has nausea, vomiting, and diarrhea, they're going to often need replacement therapy of potassium. So that's a medication that we are giving IV sometimes. We can never, ever, 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 ever give potassium IV push. It will kill your patient. Okay, it's given in a bag, extremely dilute, and it's given over a very, very slow time period, okay? Sometimes it's mixed in with their primary fluids, and sometimes it's hung as a piggyback, but most often it's mixed in a large volume to ensure that we don't give it too rapidly, okay? Potassium cannot be pushed. And then we're most often seeing this, in ambulatory care center or home health settings. All right, restorative therapy is when we restore daily vital fluids and electrolytes. The type is determined by the lab testing. So it's going to be dependent upon very, very similar to maintenance therapy, what they have lost, okay? So if we're replacing or we're restoring, we need to just ensure that we're giving back what they need. We need to make sure that we're not giving, if they've lost, okay, let's just say that they've lost a lot of intracellular volume. We want to give something that's going to, restore those cells. If they've lost a lot of extra cellular volume, then we want to give something, and y'all are going to learn about hypotonic and isotonic solutions and hypertonic, and the physician is going to determine what type of fluid is given. So if y'all want to look, let me see. All right. On page, in your Roche's Foundations book, your Roche's Pharmacology book, on page 662, there's a little box that says preferred IV solutions. So lactated ringers is a very common IV solution. It's usually given for burns, trauma, OB procedures where significant blood loss occurs. So we also hung lactated ringers in pre-op because for our patients that we anticipated to lose a lot of blood. Normal saline is compatible with blood products, and it's often given to patients with kidney disease or heart failure. Half normal saline is given in the event of hypernatremia because it actually causes fluid to move back into the cells. So by doing that, it dilutes that solute a little bit that's inside of the cells and can help with that hypernatremia. Plasma Light A is used in place of lactated ringers and is also compatible with blood products. And dextrose in water is used when your patient is dehydrated or we need to reduce the potassium or sodium blood levels. So those are just some examples of when we would use certain types of solutions.
Did you say that was on?
Say it again, I'm sorry.
What page did you say that was on?
On page 662 in your Roche's Foundations book. It's a little box in the top right. All right. There's a very similar box on page 702 in the green fundamentals book. And in addition to the examples of use, it tells us whether those solutions are isotonic, hypotonic, or hypertonic. I want y'all to note that half normal saline, 0.45, half normal saline is hypotonic. And it is the only one that is listed with the tonicity of hypotonic. Hypotonic solutions contain less solute than extravascular fluid, and they cause fluid to shift out of the vascular compartment and into the cells. That is a good thing if your cells are if your actual cells are dehydrated and you have hypernatremia, we want to move some of that fluid in. But if your cells are sitting pretty and you just have loss of fluid extracellularly, and we give a hypotonic solution, it could actually cause those cells to rupture. So for this reason, they are considered unsafe to give to children. Okay, that's hypotonic solutions, and the only hypotonic solution that we're going to talk about is half normal saline, and that's listed as 0.45% saline. Okay, you need to know that normal saline is 0.9% saline. Okay. So while we're talking about hypo and hyper, so isotonic solutions have the same concentration or osmolality as the blood, and they just expand the body's fluid volume. Whenever your body is exposed to isotonic solutions, the body cells stay approximately the same size. So there's no major shift that takes place with your isotonic solutions. Are y'all following me on that? If you think about your vessel, and then you think about your cells inside of your vessels, and then you think about all the plasma surrounding it, y'all remember about osmolality and stuff moving into the cells and out of the cells. Because we're injecting directly into these intravascular spaces, we have to be mindful and know what's happening. So examples, this is all in your book, and it may be later on into the chapter as well, but I was kind of on it. So examples of isotonic solutions are normal saline, 5% dextrose in water, and lactated ringers. And then examples of hypertonic solutions are 10% dextrose in water and 5% dextrose in lactated ringers. So again, with restorative therapy, we are most concerned about the dangers of fluid overload. Signs and symptoms of fluid overload are elevated blood pressure, shortness of breath, chest pain, and edema. All right, in regards to blood products, we're going to have a whole chapter on blood products. But with blood products, we generally want to infuse what is lost. So when we, most often we give whole blood. When we check our patients, we're looking at their H&H, we're looking at their white count, we're looking at their red blood cells, and we're looking at their platelets. But if we look at that, so normally we're given whole blood, which includes plasma, white blood cells, platelets, and red blood cells. If we're looking at our patient and the only thing that is low is their platelets, do they need whole blood? No, we're only going to give them platelets, okay? So we will have fresh frozen plasma, packed red blood cells, and platelets. So I've just accidentally said we often give whole blood. We actually often give packed red blood cells because most of the time when their red blood cells, their hemoglobin and hematocrit are low, then we need to replace their red blood cells. In addition to blood, there are colloid expanders. So some religions, and have y'all learned about that? Did y'all learn about that in Foundations? It is your patient's right to refuse blood transfusions. Some people are against it for religious reasons, such as your Jehovah's Witnesses, and some people just do not like the idea of having someone else's blood in their body due to fear of being infected with something, numerous reasons. It is their right to refuse blood. But there are other things that can be given, such as colloid expanders, like albumin and dextran, or LR, with dextrose. And those things can still expand. Their red blood cell may not go up, but it would increase their pressure. You know, some of those secondary problems related to having that blood loss, it would, you know, it could fix that. And so knowing what their actual, I don't know the right word. Excuse me 1 second, y'all. Y'all hang on for 1 second. I'm sorry. Hey guys, I apologize. I had to take this phone call. Y'all take a 10-minute break and I'll pick up where I left off, okay? All right, sorry.